Our next topic is anxiety disorders. Anxiety is something that everyone goes through almost every day. It is basically the anticipation of future threats. That think of anxiety as what you would feel if you were riding a roller coaster and you reach the top of the roller coaster and now you know the roller coaster is going to fall down. The worry you have then, the hypervigilance, the activation of your autonomic nervous system, this is what anxiety is. And anxiety can present itself when you are dreading something in the future, such as an upcoming exam, a job interview, anything that will occur in the future. And this is the most common psychiatric problem in women of all ages. And men who have anxiety usually have a substance abuse disorder. The problem with anxiety is it does not usually require treatment, but in some cases it can lead to depression. When we talk about the treatment of anxiety, the first line is usually considered as cognitive behavioral therapy. Again, we will talk about treatment for psychiatry in a later chapter. This is usually the first step that a psychiatrist would attempt in treating anxiety. If it does not work, you go for SSRIs, SNRIs, which are also considered first line. And then you would go for the second line drugs if these drugs have side effects which are not, which the patient says is not working for them. So if they have sexual impotence, they can go with this drug, buspirone. Signs and symptoms of anxiety. Since this is a topic that is best discussed in case studies, I will not go through this. Also, this is something that everyone goes through and it's not something difficult to understand. The next topic, generalized anxiety disorders. The first thing is, this is excess anxiety and worry about different aspects of daily life for the most days of 6 months or more. To diagnose a person with generalized anxiety disorder, the person must have this disorder for at least 6 months. And again, think of being on top of a roller coaster and think of what you would feel then. You will have motor tension, you are fidgety, you are jumpy, you have autonomic hyperactivity, you are vigilant, you are fearful and worried, and obviously with autonomic hyperactivity there's going to be sleep disturbance. Now let's take a look at a case of anxiety. A 25-year-old woman comes to the psychiatrist complaining of fatigue and difficulty sleeping for the past 8 months. She reports having difficulty concentrating on her studies, being extremely irritable, and is continuously worrying about losing her job despite recently being promoted. She has started isolating herself from friends and families due to feeling unwelcome. So in her mind, she feels that if she goes to these functions, she would be unwelcome. Her physical examination reveals no findings. As you can see, this patient has been suffering this condition for over 6 months. In this case, 8 months. And the patient has all the symptoms of anxiety. So this patient is considered as generalized anxiety disorder. Now, generalized anxiety disorder must be differentially diagnosed with depressive disorders, schizophrenia, we will talk about these, dementia, substance abuse, and most importantly, thyrotoxicosis or hyperthyroidism, pheochromocytoma, this is a tumor secreting epinephrine in the adrenal gland, and hypoglycemia. Also, when a person is sick, they can be anxious about that sickness. So this can manifest secondary to a physical illness. Causes include any stressful event and experiences, and there is also a genetic predisposition. Similar to depression, there is a A genetic predisposition, if your parents or your mother, father, someone has depression, there's a risk of anxiety along with the associated disorders including panic disorders, agoraphobia, and major depression. The treatment is usually non-pharmacological. You usually try to help the patient and you teach them relaxation techniques such as meditating, anything that will help them relax, yoga, whatever it is. Then cognitive behavioral therapy, we will discuss that in treatment. And there's something here. Exposure therapy does not help in most cases. We will talk about exposure therapy in phobias, but in generalized anxiety disorders, it does not help in most cases. Again, pharmacological management, we can use a diazepam for acute onset GAD or for short-term treatment. We do not use these drugs long-term. And SSRIs can be used for long-term management of generalized anxiety disorders. We will talk about these SSRIs in the treatment chapter. Our next topic is post-traumatic stress disorder, PTSD, and acute stress disorder. These two topics have the same pathology, but what differentiates the two is the time period. Acute stress disorder is diagnosed if the symptoms do not last longer than a month. Acute stress disorders. But PTSD is anything longer than a month. This is considered PTSD. Let's take a look at a patient with chronic PTSD. A 25-year-old soldier is sent for a psychiatric evaluation 2 years after serving 3 tours in the Persian Gulf. He witnessed fellow soldiers in his brigade get killed by a rocket explosion. So this is a traumatic event. He saw that and he states that he cannot get these disturbing images out of his head, even after returning home. Now, this patient had experienced a traumatic event, and since that point, he's unable to get these images out of his head. He says he does not fall asleep. The patient will have recurrent nightmares. He's constantly on guard, even with his family. There will be a lot of fighting involved. He has been living alone due to a strained relationship between his wife and children. The problem with PTSD is these patients have been exposed to some sort of stress. It could be war, rape, earthquakes, and the anxiety comes in and making them fear by causing them to relive that event. So they will daily relive that event and will do absolutely anything to avoid remembering that event. This could mean they could abuse substances like alcohol. That's a very common thing that happens. And also, they can even attempt suicide or complete suicide. These patients are easily startled, hypervigilant, and exhibit sleep disturbance. So basically all these anxiety symptoms. And they are prone to anger outbursts and have difficulty concentrating. Again, if these symptoms last longer than 1 month, it is diagnosed as PTSD. If it is less than a month, it is diagnosed as acute stress disorder. The treatment for this, we will go into detail of these drugs later, is basically counseling or group psychotherapy. And if you go for pharmacotherapy, you use SSRIs and benzodiazepines. SSRIs for long term and benzodiazepines usually for short term. We do not give these drugs long term. The next topic is phobias. Phobias are irrational fears of something which makes it impossible to reason with them. You tell these people, don't be afraid, it's just a spider. No matter how many times you tell that, they will still be afraid. There's 2 types of phobias. Okay, we can consider agoraphobia as the third, but usually specific phobias are for a specific object. And then we have social phobias, which is usually the fear of being around others in social situations. Let's take a look at specific phobias first. Specific phobias could be due to fear of some object, animals, situations that causes the person to experience anxiety symptoms. These patients will be suffering anxiety symptoms, and usually these could be due to a childhood fear. The child was afraid of spider, and this continued into adulthood. And there is genetic factors, family histories, and the treatment for this is considered as exposure therapy, where the stimulus is gradually exposed to the patient. So if the patient is scared of spiders, let's say this patient is scared of spiders, you show a picture of a spider the first day. And when the patient is okay with that picture, you next show a video of that spider, of a spider. And then you show a spider at, let's say, a distance. And gradually, till the person is able to touch the spider without fear, you continue this exposure therapy. And you can prescribe benzodiazepines to relieve the associated anxiety, so that they will be less afraid to go and touch the spider. Next, we have agoraphobia. This is fear of open spaces. So usually it's that they are vulnerable, they feel like they are vulnerable when they go out in public spaces, in public transport, and these patients usually tend to stay at home, and these patients will live with a lot of anxiety and will not leave their houses. And usually the treatment is similar to the specific phobias, where you educate the patient, you develop an anxiety scale, or you expose this patient to the outside. You tell the patient, look out of the window, go to the door, open the door, look out. Next, take a step outside, and gradually expose this patient to that uncomfortable situation. You can give the anxiolytic drugs such as benzodiazepines, SSRIs, to treat this agoraphobia. Next, we have social phobias. Social phobias is the fear of feeling or being stupid around other people. So in a social situation, they are afraid, what if I say something stupid? There's two types. There's the generalized, in which in a party that person would either not go, they would have panic attacks and they would not go, or even if they go, they would hide and try to be as inconspicuous as much as they can. Then there's the performance type phobia. This is basically stage fright. The fear of speaking to a large crowd, and usually one thing that works in their head is that they might urinate on stage. And the treatment for performance type phobia is usually a beta blocker, which is given, a low dose is given prophylactically around 30 minutes before the event, and this will help the person manage the phobia symptoms. Now, alcohol misuse is more common in social phobias than other phobias. This is pretty obvious. A person who's afraid of spiders is less likely than someone who's afraid of social situations to abuse alcohol. Let me talk a bit about systemic desensitization, flooding, and exposure. Systemic desensitization is when the person has more than one phobia, and the person is usually asked to list them all down and to tackle each of them through meditation, breathing, and other behavioral therapy methods. Flooding is, as the name says, the person is given a massive exposure. If the person is afraid of drowning, the person is thrown into a pool. And exposure is what we talked about. This is a gradual exposure. This is a massive exposure. So the gradual exposure is what we talked about with the example of the spider, where the person is gradually desensitized to the spider. Next is the topic obsessive compulsive disorders. Obsessions are anxiety provoking thoughts. So these thoughts are anxiety provoking, and the person must act on these thoughts. Compulsions are actions which are beyond your control, and this can cause severe distress. So everyone has some sort of OCD. When you lock your vehicle, most people would press the key fob twice, because the obsession is, was the car locked? And the compulsion to get rid of the obsession is by pressing the key fob twice or three times at least. You have to do that. If you don't, you become anxious. You think, what if someone breaks into the vehicle? If you didn't lock the vehicle 2-3 times, until you are entirely sure. This becomes a psychiatric problem only when it affects their daily life. If they spend more than 1 hour a day trying to deal with this obsession, this is considered a psychiatric problem, such as hand washing. Now, let me give an example of a patient I saw. This patient was bullied in high school, and it is most likely that the people who bullied him, they made him, when he was a child, they made him touch sperm or something related to that. And since that day on, he always had the obsession, the fear that it could happen again, or that his hands are still contaminated. And compulsively, he has to wash his hands for at least an hour or two every day. This is very common when there is childhood trauma, and it is known by the patient that this is an absurd behavior. Now, this part is very important. The patient knows that this is an absurd behavior. They know that this is wrong. They should not be doing it. But when the obsession comes, the anxiety is too powerful for them to overcome that. So they have to go and act on the obsession. This point is important because there are some people in which it is part of their personality. We will talk about personality disorders, but personality disorders is basically who the person is. It is not something they can control, or they do not see that as a wrong act. They see that as their normal functioning. So if it is obsessive compulsive disorder personality, obsessive OCD personality, that means the patient will not recognize that behavior as absurd, but will consider it to be normal. In OCD alone, it is considered as an absurd behavior, and it is associated with Tourette Syndrome. We will talk about this shortly. And it is more common in males than females, and 2/3 of them can develop major depression. This is a serotonin related syndrome. We will talk about serotonin, which I call the happy hormone. This is a serotonin related syndrome. So the treatment is to increase the serotonin levels by giving SSRIs, and you can try cognitive behavioral therapy. We will talk about this later. And TCAs are considered second line because of the side effects. Next, it's a topic called Trichotillomania. This is basically syndrome in which the person pulls out their hair. The person will excessively pull out their hair, usually during times of stress or work. And these patients, it could go on through different degrees. You could not, in most patients, you won't notice it, but in some patients, you can see patchy hair losses, and usually they do not know that they're doing it. It happens subconsciously. Some patients will even eat that hair, the hair that they took out. Some of them will tend to eat that hair. This can cause significant distress, and attempts to stop is usually seen. And there can be areas of balding, especially in the scalp. Some patients will eat up the torn hair, and this is common mostly in childhood, but it can span all ages. The treatment for this is cognitive behavioral therapy. You don't admit the patient, you don't give them drugs, you try to change the behavior. Our next topic is Tourette Syndrome. If you watch the movie Predator, the newest movie, there is a person who has Tourette Syndrome, where the person is in his 40s, has symptoms of vocal and motor tics. What are tics? These are sudden, repetitive, non-rhythmic motor movements or vocalizations. So usually they will be making weird noises with their throat. They will be clearing their throat. They will be like, and sometimes they can speak words, profanity, bad words. The thing is, this is an anxiety-inducing situation in which the person knows that he shouldn't say it, but to get out of that anxiety, he has to say that. It builds up in him, and the only way to relieve himself of that anxiety, is by telling it out. They can't control that. This is more common in males, and most importantly, the diagnosis must always be before age 18. After 18 years of age, this condition is not seen. So let's take a look at this case. A 17-year-old boy comes to the primary care physician due to unusual behavior at home and school for the past year. His marks are relatively good. They do not have problems with their IQ or learning abilities. The problem is they have symptoms such as throat clearing, or shrugging their shoulder, or blinking excessively. This is usually seen during the physical examination. When the doctor examines this patient, they will see these symptoms, and very importantly, these symptoms are not seen during sleep. These symptoms occur when the person is awake. Treatment includes antipsychotics. We will talk about this: psychoeducation, behavioral therapy. These are the treatments used. Next, let's talk about panic disorders. Now, it is important to know that there are two types: panic disorders and panic attacks, and the treatment for these two is very different. Panic disorders, when a person usually comes to you as a doctor, they will tell you a story. The person is driving, reading a book, or doing some activity, when suddenly they get the feeling that something terrible will happen. This is called panic disorders. Panic attacks occur out of the blue, where they will have palpitations, paresthesias, depersonalization, intense fear of dying or going crazy, choking, sudden, severe attacks. So these symptoms are better learned in case studies, which we will go through. But it's important to know that there's a difference between panic disorders and panic attacks, because the treatment is different. Panic disorders is usually a person is doing something and suddenly they get this feeling that something horrible will happen. But a panic attack is a sudden onset of symptoms with palpitations and abdominal pain, nausea, fear of dying, all of these which can occur, and it is more common in women. And usually a person is diagnosed as having panic disorders when there is a minimum of 3 attacks in 3 weeks. Now, the most important thing is the treatment. How do we treat a panic attack? So the first aid is usually to give these patients a paper bag to breathe into, and then the carbon dioxide that is released, it will help to decrease the rate of respiration in our brainstem. Next, we can treat them in an acute setting using benzodiazepines. There is an important thing that we need to know, that is in choosing the correct benzodiazepines. So a panic attack in a patient with liver disorders is treated different in patients who have a panic attack and who have a risk of getting addicted to that drug, the benzodiazepines. So patients with liver disorders, there's a mnemonic, it's called OTL, outside the liver. And O stands for oxazepam. This is temazepam. And L is lorazepam. These are drugs that you give a patient who has a risk of liver disorders, such as long-term alcoholics. Then if the patient has a risk of addiction, we give a drug which has a long half-life, such as clonazepam. Long-term treatment of panic disorders includes SSRI. Venlafaxine is first line. Benzodiazepines are used in acute settings, but usually not in long-term treatment. So the usual treatment will start off like this: an SSRI plus a benzodiazepine to control the panic attack. Then you go for SSRI while reducing the benzodiazepine dosage, and finally you manage the patient long-term with SSRIs. Next, let's discuss some cases related to the topics that we did. Question number 1. So you can pause the video to try the questions out yourself. I will go on with these questions. A 20-year-old college student comes to the office due to recurrent episodes of chest pain, palpitations, and shortness of breath over the past few months. During some episodes, she experiences dizziness and diaphoresis, and the episodes last 5 to 10 minutes. The patient constantly worries about when and where she will have another one. This, in all aspects, looks like it's a panic disorder. And this is the reason why it comes under anxiety, under DSM-5. The patient is worried about when it will happen again. This keeps happening, and there's no one who's able to tell why it happens. Lab testing is done, vital signs are normal, physical examination is normal, and the most likely diagnosis is a panic disorder. We'll talk about these in upcoming chapters. We talked about generalized anxiety disorder. Factitious disorder is usually when there is something to gain. Generalized anxiety disorder is diagnosed when there's 6 months of anxiety. We will see a case next regarding that. Illness, anxiety disorder. This person does not have any illness, so there's no related anxiety for that. A 30-year-old woman comes to the office due to worsening fatigue and tension headache over the past year. She describes always feeling on edge and lies awake at night worrying about various issues, such as if she's good at her job, if her husband loves her, and if she will get cancer one day. all seems like she's anxious about her life. And there's a very important clue. This is greater than 6 months. And she's anxious about various issues of her life. So it sounds like this patient has generalized anxiety disorder. During the day, she feels tired and her shoulders and neck aches. She has difficulty concentrating on her work and has become increasingly concerned about losing her job. Physical examination, including thyroid function tests, all of these are normal. And this patient's anxiety has never been treated, but once she took a tablet of alprazolam offered by a friend, which reduced her anxiety. But the effects did not last long. This is a short-term treatment, and the patient drinks wine on rare occasions and does not use any drugs, which is the most appropriate pharmacotherapy for this patient. So, alprazolam is used for acute settings of a short-term treatment. These diazepams. This is a beta blocker. Citalopram is an SSRI. We will discuss these when we come to that chapter. SSRIs are used for the long-term treatment of generalized anxiety disorders. Next, let's take a look at question number 5. A 19-year-old college freshman comes to the office due to tension, headache, and neck pain. He has had these symptoms for many years, but they have increased in frequency over the past 7 months since he started working part-time. The patient attends college and says that although his grades are passing, he feels overwhelmed and fatigued. I can't concentrate on my schoolwork and worry that I will flunk out of school and never get a good job. He sleeps fine and frequently worries about his grades, health, and social life. He obsesses about minor comments his friends have made about how serious he is and gets depressed thinking that he is not attractive enough to get a girlfriend. Which of the following is the most likely diagnosis? The person is not adjusting to a new life. Generalized anxiety disorder is the most likely answer, considering the time period, and the person is worried about multiple things in his life. In psychiatry, in terms of questions, the time frame is very important. A 10-year-old girl is brought to the office by her mother as she is concerned that her daughter seems overly anxious about eating and says during lunch she spends an hour cutting the food on her plates until all the pieces were the same size. Cutting the food on her plate until all the pieces were the same size. This seems like an obsession. The patient recently became a vegetarian and spends hours in the grocery store selecting vegetables and checking nutritional information. She also seems very concerned about her appearance. She brushes her hair 21 times on each side, parts her hair strand by strand, and plucks her eyebrows for an hour daily. The patient says, if I don't keep things exactly even, I'm afraid something bad might happen. The patient is medically healthy and has not yet started menstruating. BMI is 20.5, that is normal. Physical examination is normal, except the lack of these eyebrows which she has plugged out. Which of the following is the most likely diagnosis? These are eating disorders, associated with eating disorders. Trichotillomania is pulling out the hair, but then this patient seems to have something which is much more serious. Obsessive compulsive disorder. Okay, when I say serious, the person knows that there is something wrong. So it cannot be a personality disorder. However, this patient has to spend at least 1 hour attending to these obsessions. Cutting the pieces to equal sizes, plucking her eyebrows daily, parting her hair, brushing her hair exactly 21 times, keeping things even. These are all obsessions, and she has to act on these which are called compulsions. A 30-year-old man comes to the office due to problems with irritability, anxiety, and low self-esteem. He was recently fired due to poor work performance at his entry job and worries about finding a new job and supporting himself. The patient is currently in a relationship but mentions that his girlfriend is upset by his frequent lateness and forgetfulness. A further history indicates that his problems are long standing and date back to childhood when he had behavioral problems in school. The patient feels overwhelmed due to being disorganized. He frequently procrastinates, bored at work, and jumps to another project before completing what he's working on. This point is very important. On mental status examination, he is cooperative and talkative, but appears tense, restless, and easily distracted. These are typical signs of ADHD. Now, why does this person have behavioral problems in school? Obviously, due to the ADHD, they will act out. Then, when they get punished or when they are bullied by their mates, they will have conduct disorders. They can go on into antisocial disorders, but this person does not seem to have such an effect. However, they also risk abusing alcohol. We will talk about these in the relevant chapters. Which of the following is the most likely diagnosis? Not an adjustment disorder, attention deficit, ADHD. Our next topic will be on bipolar disorder. Next, let's take a look at this 8-year-old boy who's brought to the office due to worsening behavior in the classroom. Although the child sits quietly, he disrupts the class with repetitive sniffing, throat clearing, and grunting. His teacher has complained the boy distracts the class and his focus in class is poor. The behavior worsens when stressed or excited. Physical examination shows frequent eye blinking and shoulder shrugging, but is otherwise normal. Metabolic panels are normal. Which of the following is the most likely diagnosis? The answer is Tourette Syndrome. A 30-year-old woman comes to the office due to worsening anxiety and insomnia over the past 2 months. She says that there seems to be something wrong with her because she feels very anxious. She says she's worried that this part has been repeated. She feels panicky for no reason. Her heart races and she starts sweating, and she has lost 5 pounds without even trying. The person has no significant medical history. Her blood pressure is elevated, pulse is elevated. The patient is restless, has warm, moist hands, and mild tremors bilaterally. These are not conditions which can be brought on by psychiatric conditions. There has to be a medical condition. My guess is increased thyroid hormone, hyperthyroidism. Hyperthyroidism can cause anxiety, which is secondary. A 50-year-old man comes to the office due to excess skin shedding and cracking. The patient explains that he washes his hand every time he touches something due to the fear of contamination. He spends more than an hour a day washing his hands and sometimes multiple times daily. He was recently fired for not being willing to use the same devices as his co-workers. He's worried that he will be unable to find new employment. Which of the following is the neurotransmitter most likely affected? We talked about this. This is OCD, and the neurotransmitter associated with OCD is serotonin. A 55-year-old woman comes to the office for checkup. Her medical history is significant for hypertension and hypercholesterolemia. The person confides that she has been feeling down since her youngest child left college a month ago. The patient is worried about her daughter being away from home and occasionally loses concentration, worrying about her daughter, However, it has not affected her productivity. This point is very important. Physical examination is normal, which is the most likely cause. This is normal sadness. If her work is affected, then it could be a depressive disorder, but this, in all likeliness, seems to be normal sadness after the child has gone from the house. A 25-year-old man comes to the office due to recurrent anxiety attacks over the last several months. He says that the attacks come suddenly and subside rapidly. The person is worried that it could happen while working or driving. The person says that during these attacks, he feels sudden faint, starts shaking, and the heart races as if it's trying to jump out of his chest. This seems to be a panic attack. The person has a history of alcohol abuse recently, and on examination, the patient appears calm and normal. Which of the following is the most appropriate pharmacotherapy? If the patient is having an acute episode, the treatment would be this. But as you can see here, physical examination shows no abnormalities. The patient appears calm and vital signs are within normal limits. So the most appropriate long-term treatment to stop these occurring again is an SSRI. This is for acute management. This is long-term and also considered the first line. The next question, we will learn it with the next chapter. A 15-year-old girl is brought to the office. The mother explains that the daughter has always been anxious with a sensitive stomach, but the symptoms have worsened since the daughter's best and only friend moved away. She prefers to stay at home and does not participate in school activities. The mother says she was worried for weeks about going to a party, and on the night of the party she had an anxiety attack and ended up not going. The patient says she's shy and afraid of looking stupid around others. What does this seem to be? A social anxiety disorder. Physical examination shows no abnormalities. During the interview, the patient makes little eye contact, again, typical of these conditions, and give brief answers to questions. In social anxiety disorders, the patient does not like to appear stupid. So what they do is they give short answers, they hide, they are basically introverted in the situation. Social anxiety disorder. A 60-year-old woman comes to the office due to insomnia and depressed mood. She describes feeling angry and sad since her husband of 30 years unexpectedly announced that he wanted a divorce 2 months ago. She says, "I was devastated because it came out of the blue." The patient stays up past her usual bedtime, worrying about living alone and supporting herself financially. She has recently started drinking wine to help fall asleep. Although she was regularly eating lunch with her friends, she has cancelled multiple times because she can't bear to go through the whole story again and again. She has no suicidal ideation, which is seen in depression. We will talk about depression in the next chapter. The patient is tearful when discussing the divorce, but brightens when asked about her children. This is not seen in depression. This is not seen in depression. Which of the following is the most likely diagnosis? Now, depressed patients, they wake up depressed, they spend the day depressed, and they go to bed depressed. Nothing seems to help them be happy. This most likely is an adjustment disorder. There's no trauma. There's no recurrent trauma. There's no nightmares. Time period is 2 months. Insomnia disorder. She has other symptoms which says this is not just an insomnia disorder. Major depressive disorder would not be the answer because she feels happy when talking about her children. Let's take a look at question number 19. A 22-year-old man comes to the University Health Center after being referred by his roommate. The patient says his professor got annoyed after he requested several extensions for his first writing assignment. He says, "My report has to be perfect. I don't want my name on just about anything." The patient repeatedly mentions that he was the valedictorian of his high school because he was the most diligent and dedicated student. He has developed his own method of test preparation, which includes spending a few hours every morning planning out his daily study schedule. The patient studies alone in the library every evening after class and on the weekends. He was invited to join a study group but declined because the other students refused to adopt his approach. The patient lives alone and denies having any hobbies because they are a waste of time. Which of the following best explains this patient's behavior? Adjustment disorder with anxious mood? No. This patient has no symptoms which says that he's adjusting to something new. Narcissistic personality disorder. Let's take a look at the other question. Answers. Obsessive compulsive disorder. It seems to be that way. He's obsessed about the report being perfect, and his compulsion is by asking for several extensions. However, this does not seem to be just an obsessive compulsive disorder in which he's aware of his problem. In all aspects, it seems that this is his personality. He's unaware about this. So the answer is D. A 38-year-old woman comes to the office due to anxiety and poor sleep. A week ago, the patient went on a family hiking trip, which ended when her brother slipped and fell 30 feet down the mountainside. Although his condition is now stable and improving, the patient worries about his recovery and awakens multiple times in a night in profuse sweat. She's unable to take naps because she feels too wound up. The patient tearfully says, "I keep reliving the moment he fell and I can't block it out." This seems to be either acute stress disorder or PTSD. And since we have the time frame here, it seems to be an acute stress disorder. Medical history is non-contributory. She has started drinking 3 glasses of wine at bedtime to calm down, but does not use recreational drugs. Vital signs and physical examinations are within normal limits. On mental status examination, the patient appears tense and nervously taps her foot. She describes her mood as numb. This is also a very common situation with PTSD patient. Which of the following is the most appropriate management of this patient? The answer for this is cognitive behavioral therapy.